Great. I'll start right at noon. So I guess all friends joining us today. So great. Thanks, guys, for taking the time to be here. All right, I'm going to get started. My name is Chris Rogers. I'm a physical medicine and rehabilitation physician here in San Diego, California, and I'm joined by my colleague, Dr. Edmund Evangelista, who's also board certified physical medicine and rehabilitation. And today we're going to talk with you about a very common form of osteoarthritis, and that is the osteoarthritis and other conditions related to the hip. And it's not an infrequent thing that we see. Actually, every week we see people who have pain in the hip. And this company was started 6 years ago with the sole purpose of providing innovative therapies that were not yet readily available, and trying to perfect those therapies to help people be relieved of their pain, and in many cases avoid surgery or other forms of treatments. So Dr. Evangelista will be speaking about the hip, give you a little information about what causes pain in the hip and treatment options that are available. That'll be our first 30 minutes. And then the next 30 minutes, we'll take some Q&A from the audience. If you look at the bottom of your Zoom, there's a Q&A section where you can type in your questions, and we'll be reading those questions and answering them for you in the second half. So again, thank you everyone for joining us today. We're glad you're here. And without further ado, we'll let Dr. Evangelista tell us a little bit about pain in the hip.
Thanks, Chris. So I'm going to share the screen of my slides here. Okay. So I'm going to talk about hip pain, common causes and treatment options. First, for a brief review of the anatomy, the hip joint is a typical ball and socket type of joint. So the ball is the femoral head here. The socket is called the acetabulum. Covering the ball and the socket is articular cartilage, which serves as cushioning for the joint. Next slide shows the labrum. The labrum is a fibrocartilaginous structure that surrounds the rim of the socket and serves to help deepen the socket and provide stability. Some of the bony anatomy around the hip that's important: the iliac crest up here, which is that bony prominence up around your waist. And then further down on the side of the hip is the greater trochanter. This is the attachment point for some of the important muscles, the gluteus minimus and medius muscles and tendons attach here. Down low is the ischial tuberosity, which is the sits bone where the hamstrings attach. The back of the pelvis is the sacrum, and the joint between the sacrum and the iliac bone is known as the sacroiliac joint. Then there are several muscles around the hip. Some of the important muscles include, again, the gluteus medius muscle here and gluteus minimus muscle. These muscles go from the iliac bone down to the outer part of the hip to the greater trochanter. The third gluteal muscle is the gluteus maximus muscle here, going from the sacral area and iliac area down to the outer femur. Then you have the iliotibial band. The tensor fasciolatum muscle on the side of the hip turns into this long fibrous band that crosses the side of the hip all the way down to just below the knee. In the back of the hip, there are several muscles, including the piriformis. And in the front of the hip, you have the hip flexors or iliopsoas muscle in front of the hip and groin area. Then there are several bursa around the hip. You have bursa all over your body, around the hip joint, knee joint, and shoulder joint. Bursa is a small fluid-filled sac that allows normal gliding motion between muscles, tendon, and bone. So around the hip, the most important bursa is the greater trochanter bursa or trochanteric bursa on the side of the hip. Below that, there are two smaller bursa beneath the gluteus medius and minimus tendons. In the front of the hip, you have the iliopsoas bursa. So what are the different causes of hip pain? You can have pain from the joint itself, from osteoarthritis, which is wear down of the cartilage in the joint. You can have a tear of the labrum, which can also cause pain from the joint. And then a condition called femoral acetabular impingement, which is basically a pinching or impingement of the femoral head and neck up against the roof of the shoulder or the acetabulum. And then any of the soft tissue structures that we reviewed can cause pain around the hip. So if you have inflammation of any of the bursa around the hip, we call that bursitis. And then you can have inflammation, tendonitis, or tearing of any of the tendons that can cause pain. So the gluteal tendons, hamstring tendon, or the iliopsoas tendon can all be painful structures around the hip. Then there are other causes of hip pain. The sacroiliac joint can cause pain in the back of the hip and occasionally in the groin due to arthritis. Patients can have sacroiliac joint dysfunction where there's abnormal rotation or alignment of the SI joints causing pain. And then you can have issues in the lumbar spine, the lower back, that can cause pain into the hip area, such as a disc herniation, pinching on a nerve can cause pain in the front, back, or side of the hip. If you have arthritis in any of the joints of the back, facet arthritis, or disc degeneration, it can cause referred pain into the hip area. This is a diagram showing the lumbar nerve root pain distribution, a dermatomal pattern of the different nerve roots that can cause pain into the lower extremity. So for example, if you have a pinched L1, L2, or L3 nerve root, it can cause pain into the front of the hip and groin, along with numbness and tingling. If you have a pinched L4 nerve root, it can cause pain into the outer hip, down to the front of the knee and inner lower leg. And then an L5 or S1 pinched nerve can cause pain to the back of the hip or buttock area and down the back of the leg. So you can see there's many different causes of hip pain. So it's important to get a proper diagnosis, and we do that through a thorough history, a thorough physical exam, looking at both not only the hip joint, but also the lumbar spine. And then we do have our imaging studies, X-rays, MRI, and ultrasound are all important at diagnosing the exact cause of the hip pain. And I think it's important to see an appropriate specialist, someone who treats hips and lower back, kind of looking at the whole picture. That way you get a proper diagnosis right off the bat. Because we see a lot of patients who come in, they've been in therapy for several weeks or months for hip pain when it's actually coming from their lower back. And vice versa, we see patients with sciatica or a pinched nerve in their back when it's actually a problem in their hip, causing referred pain into the leg.
And sometimes we see patients who have a little bit of each.
True, exactly.
Making it more challenging to separate where the pain's coming from.
Yep. So now I'm going to talk about the two most common conditions that we see in patients that present to our clinic with hip pain. The first is hip osteoarthritis, and the second is greater trochanteric pain syndrome, or greater trochanteric bursitis and gluteal tendinopathy. So first I'm going to talk about hip arthritis or hip osteoarthritis. Again, that's a wear down of the cartilage, the articular cartilage in the hip joint. The causes, it's typically a wear and tear type condition that can be caused from just normal aging, injuries to the hip joint and the hip cartilage, excessive weight, and sports or overuse can contribute to wear and tear of that articular cartilage. So patients who are involved in a lot of impact running sports, jumping sports can wear down that hip cartilage. Structural abnormalities in the hip, such as hip dysplasia, where you have a shallow hip socket, can predispose you to getting earlier arthritis. And then there are genetic components that can contribute to hip arthritis. What are the signs and symptoms? Patients with hip arthritis will typically complain of pain in the front of the hip or groin area. Occasionally, patients can have pain over the outer aspect of the hip or thigh, or even in the buttock area. Commonly, we see patients that have hip arthritis that will have referred pain down the front of the thigh down to the knee, and they'll have a lot of knee pain, which is actually coming from the hip. They have decreased motion, pain with movement. They can have trouble putting on their pants, shoes, and socks, pain and limping with walking. And on exam, we see that they have diminished motion of the hip joint and pain with range of motion testing in the hip. Imaging studies, x-rays, we can see joint space narrowing and bone spurs on x-rays. So that's a pretty diagnostic of hip arthritis. MRI can show you the earlier stages of hip arthritis where x-rays may be fairly normal. There's still a nice joint space, but we can see wear down of the cartilage on MRI at the earlier stages. Treatment, modification of activities or trying to avoid the impact activities that are aggravating the hip cartilage, weight loss to reduce stress on the joint, physical therapy to help improve motion, flexibility, and strength around the hip, and then medications such as Tylenol and your anti-inflammatory medications to help pain and inflammation. Then we have the injection therapies for the hip. Cortisone injections have been a mainstay of treatment for hip arthritis for many years. The pros are that it can reduce pain and inflammation in the arthritic joint. It works relatively fast, easy to do in the office, and they can be diagnostic as well. Sometimes we see, again, patients with lower back and hip issues, and we're not sure if the pain is more the lower back or the hip, so we can do a diagnostic injection of steroid, cortisone, and anesthetic, a numbing agent into the hip joint. And if it relieves the pain, that we would conclude that indeed the pain is coming from the hip joint. Some of the cons of or disadvantages to hip cortisone injections, relief is typically temporary. It'll buy you about 3 months of pain relief, more or less depending on the severity of the disease. And there are more and more studies that show us that cortisone is actually detrimental to the cartilage. It can accelerate cartilage loss, even with a single injection. There's a condition called rapidly progressive hip osteoarthritis, which many patients don't know about. This is a condition where after a single cortisone injection, you can develop rapid progression of the arthritis in the joint within 6 months. So significant joint space narrowing and worsening of the arthritis after that cortisone injection. A recent study estimated the prevalence of this condition to be 2.8% in patients after a cortisone injection, but prior studies have actually estimated a higher prevalence of this condition where anywhere from 7 to 44% can develop this rapidly progressive hip arthritis following the injection. And then you can have systemic side effects from the cortisone injection. So even though we inject the cortisone into the joint, it is absorbed systemically. So it can increase blood sugar in diabetics. It can suppress your immune system. So we try to avoid cortisone in patients who are getting around the time of a vaccine. And repetitive cortisone shots can lead to weight gain and osteoporosis. Another downside is that it's well known that cortisone can increase risk of infection if you get a hip replacement soon after the hip replacement, cortisone soon after, if you get a hip replacement soon after the cortisone injection. So it's pretty much standard of care now that if you get a cortisone injection, a hip surgeon will not replace the hip for at least 3 months. They want to wait 3 months to make sure that cortisone is out of the system in the joint before getting a hip replacement to decrease that risk of infection. What about hyaluronic acid injections or HA injections? Hyaluronic acid is a naturally occurring substance in our joints that can provide lubrication and cushioning. And we know that with aging and with arthritis, the levels of HA in the joint are decreased. So hyaluronic acid injections are commercially manufactured gels, a gel-like substance that we can inject into the joint that can help supplement or replenish the HA in the joint. These injections may help arthritic pain by providing a lubrication or cushioning in the joint. Now, these are FDA approved for knee arthritis. However, they are not FDA approved for hip osteoarthritis. So if we inject it into the hip, it's considered off-label and it's not covered by any insurance company or Medicare. Additionally, the evidence for HA injections is weak. Many studies show that it may work no better than a placebo injection. And because of this, many medical societies have advised against using HA for hip and knee arthritis. The American College of Rheumatology 2019 guidelines recommend against the use of HA injections for hip and knee arthritis. The American Academy of Orthopedic Surgery 2021 guidelines recommend against the use of HA for knee osteoarthritis, and against the 2017 guidelines recommend against the use of HA for hip osteoarthritis. So what's the treatment at the end stage where it's severe bone-on-bone arthritis, as you see in this X-ray? Well, you have a total hip replacement, surgery. Surgery is actually very successful. With the advances in technology and surgical approaches, patients are recovering faster and having good outcomes following the hip replacement. However, we know that this prosthesis, the hip prosthesis, has a lifespan. So the hardware over time will break down and you may require a revision in the future. Estimated revision rate is about 1% per year. That's why many surgeons and patients try to avoid hip replacement at an early age. So if you have a hip replacement at age 30s or 40s, 30 years down the line, there's a high likelihood that you're going to need another surgery to revise that broken down prosthesis. So it's a hip revision surgery when you're older, and it may be at a time where you have more health problems and more risk. So ideally, we try to wait to recommend hip replacement until you're around your 60s. That way, hopefully that hip replacement will last you the rest of your life. Now, what about hip arthroscopy or scoping the hip? Typically not done for hip arthritis. Very limited indications for hip arthroscopy, usually done for labral tears or femoral acetabular impingement in patients who have a preserved joint, so not a lot of arthritis in the joint. You can also do it for a loose body in the joint. For patients who have a labral tear or femoral acetabular impingement with moderate arthritis, most surgeons will not recommend arthroscopy or scoping the hip. They would recommend just replacing the entire joint, doing a joint replacement.
For people in the audience who are not physicians, a loose body doesn't mean your body is loose. It refers to a piece of cartilage that's broken off and is floating around inside the joint, causing havoc and damage to the other tissues.
Exactly. So what about patients who have failed the traditional treatments, physical therapy, cortisone injections, even HA injections, but they're not ready to replace the hip for various reasons? We have our cell therapies or orthobiologics. We can use the cells from our blood, fat, or bone marrow to help the arthritic condition. The first, platelet-rich plasma, is probably the most common. Platelets are the cells in your bloodstream that contain numerous growth factors. So we can take your blood, centrifuge it to concentrate the platelets, and we inject that PRP or concentrated platelets into the arthritic joint. Microfragmented adipose tissue or fat. Fat is a rich source of cells called MSCs or mesenchymal stem cells, and now termed medicinal signaling cells. So we can harvest your fat from the flank area, process it, then inject it into the arthritic joint. And the third cell treatment that we do is bone marrow concentrate. So your bone marrow is also a source of MSCs as well as platelets, and we can aspirate your bone marrow from your iliac crest, concentrate it, and inject it either into the arthritic joint or directly into the diseased bone. What are the goals of cell therapy? Well, I'm not going to tell you that it's regrowing cartilage in the setting of arthritis because we're not there yet. I mean, there's laboratory evidence that some of these treatments can do that. However, it's not proven in what we can do based on the guidelines with the FDA and what we can do with our cell treatments. But we're really trying to improve that toxic environment in the joint. So in an arthritic joint, you have cells and mediators that are causing pain and inflammation and eating up that joint cartilage. So by injecting these cell therapies, we're trying to improve that microenvironment by reducing inflammation, decreasing the number of harmful cells and proteins that are causing pain and eating up that joint cartilage. We're trying to promote healing of injured areas of the cartilage and bone. We're trying to slow that degenerative process and basically delay the need for a hip replacement. So who are the ideal candidates for these cell treatments? Someone with mild to moderate osteoarthritis is a better candidate compared to someone who has severe arthritis. Once it's bone-on-bone severe arthritis, these cell therapies aren't very successful. Again, someone who's too young to have that hip replaced, if someone's in their 30s or 40s, we want to try to delay that hip replacement until a point in time where hopefully once they get the hip replacement, that'll last you the rest of your life. So we can try to preserve that joint with some of these cell therapies until they're older. Someone who may not be ready to replace that hip because of timing issues and family issues and work, they don't want to do the hip replacement yet. And then someone who may be too old or unhealthy and may not be healthy enough to undergo a hip replacement could be a good candidate for these cell therapies. So what's the data on these cell therapies for hip arthritis? This study was published in Journal of Clinical Medicine, November 2022. It's a systematic review looking at the different orthobiologic injections for the treatment of hip arthritis. Now, we like looking at these systematic reviews because instead of looking at multiple smaller studies, these systematic reviews compiles all the different studies on that same topic and analyzes the results and tries to give you a summary of the results of the treatment. So this review looked at 20 different clinical studies using orthobiologics. 12 of the studies were on PRP, 5 on bone marrow, 2 on fat, and 1 on amniotic fluid, which we can't use now because of the FDA guidelines. And their conclusion was that the available evidence suggests safety and overall promising results using orthobiologics for hip OA. They also concluded, based on reviewing all these studies, was that the treatment success was inversely proportional to the severity of the OA. And we see that. So the patients with more mild to moderate OA did better compared to the patients with severe OA, who don't typically respond to these treatments. And they also concluded that further high-level controlled trials are needed before drawing more definitive conclusions. Basically, we need more data. So we need more studies, we need better studies. And here at our group, we're trying to collect that data by having patients do our outcome questionnaires, and we're trying to track the results. Now, interesting thing in this study, they looked at 6 of the studies on PRP were randomized controlled trials comparing PRP to hyaluronic acid for hip OA. And the results were a little bit controversial. Now, we've reviewed the data for knee osteoarthritis, where they've compared to head-to-head PRP and HA injections. And based on the knee data, it's pretty clear that PRP is superior to HA. However, in the hip data, it was somewhat more controversial. 2 of the studies showed that PRP was better than HA. 3 of the studies showed that PRP was equal to HA, and 1 of the studies showed that HA was better than PRP. So a little conflicting data. I think we really have to look at the studies in detail to see why there's a discrepancy between the knee data and the hip data for comparing PRP to HA. There are different ways to formulate the PRP. Maybe some of these patients were more severe arthritis and don't respond as well. So we really have to delve into the data to see why the data is showing this.
I think, sorry to interrupt, Dr. Evangelista, but one of the things that we see commonly in the PRP literature is that not all PRP is created equal. And I don't think the average person realizes that there are more than 60 different systems for making PRP. So that means Dr. Smith in one part of town may use a system that doesn't create a PRP that's been shown to be helpful for hip arthritis, whereas Dr. Jones down the road does use a different system that makes, for example, a higher dose of platelets we found that is helpful for osteoarthritis. So when you look at these studies, it's important to realize that PRP is not the same in all these different studies, which makes it even harder to interpret the published literature. And one thing we do here at SDOMG is we have a cell counter. We know that more cells produce better outcomes. So before we inject that PRP in the patient, we actually count the number of platelets in the PRP. So let's make sure it's actually platelet rich, meaning the cell count's high, but let's make it as high as possible so we get the best possible result. And I think as we see more and more studies come out, I think soon everyone will get on the same page and start reporting that kind of data, that what's actually in the PRP, because not every study will report what's actually in their PRP, anyway, so that's just sort of a little technical thing that I think patients should be aware of and should ask their physicians, how do you make your PRP? What's the platelet count? These kinds of things do matter.
Agree. Thank you. And then there was another study, a randomized controlled trial more recently published in September of 2022. So this was not included in that systematic review because it was around the same time as the other study was published. But this compared injection of PRP to HA to a combination of PRP and HA into a patient with hip arthritis. This contained 105 patients, moderate grade arthritis. The patients were randomized to either receive a PRP injection, an HA injection, or a combination of PRP and HA into the joint. And this study showed that all three groups had significant improvement in pain and function. However, the patients who received PRP or PRP with HA did better than the HA patients at 6 months. And they also saw that there was no difference between the group who had PRP and the PRP with HA, so they didn't feel that adding the HA was beneficial to adding it to PRP. This study was another systematic review published in American Journal of Sports Medicine, June of 2022, looking at specifically PRP for hip osteoarthritis. This one looked at, again, a systematic review looking at 8 different studies where they used PRP for hip osteoarthritis, so a total of 331 patients. And they concluded that there was low to moderate quality evidence suggesting that PRP reduces pain and improves function compared to baseline. Now, why would they say low to moderate quality evidence? I believe that a lot of these studies they looked at were not randomized controlled trials, so they didn't have a treatment arm to compare to. They were a lot of prospective studies where they took a bunch of patients, did the PRP injections, and tracked their outcomes over time. So that quality evidence is not as strong as your randomized controlled trial type of study. Now I'm going to talk about greater trochanteric pain syndrome. This is the other condition that we see very commonly in our practice. Basically, this is pain over the lateral hip or the greater trochanter region. It's usually due to either inflammation of the greater trochanter bursa or bursitis, or an injury to the gluteal tendons, gluteal tendonitis or tendinopathy, specifically the gluteus medius and gluteus minimus tendons that attach right onto the side of the hip there. The signs and symptoms, these patients have pain over the lateral aspect of the hip. The pain can refer down to the lateral leg, down to the knee, or even to the ankle at times. They usually complain of pain when lying on the side. They have pain with any activity that stresses those gluteal tendons, so walking, getting up from sitting, walking up hills, or walking upstairs. And they can have pain with sitting with their legs crossed. What are the causes of this pain syndrome? Tight IT band. This picture kind of shows you the IT band coming across the hip, going from the iliac crest across that greater trochanter region, and it starts down at the knee. And you can see if that IT band is too tight, it will cause increased friction on that bursa and cause that bursa to get inflamed. So that's why we want to stretch those tight IT bands to relieve any increased friction or pressure on that greater trochanter region. Direct trauma to the bursa, so falling onto the bursa area can cause it to get inflamed. Any overuse of those gluteal tendons, excessive running, hiking, walking can inflame or tear those gluteal tendons. And just normal aging, you see with normal aging, these gluteal tendons will degenerate and wear down and start to tear and become painful. Imaging, x-rays don't really help us too much with this pain syndrome. However, we can see bone spurs at the greater trochanter where the gluteal tendons attach, suggesting chronic tendonitis or tendinopathy. Calcifications in the tendon or the attachment can be seen, but really see the best with MRI or ultrasound. Both these will show fluid or swelling in the bursa, so if there's actually a true bursitis, we can see it on both MRI and ultrasound, and we can see any pathology of the gluteal tendons themselves. You can see if there's any tears of the tendon, inflammation around the tendons on both MRI or ultrasound. Now, many cases of patients that are diagnosed with bursitis are actually not truly bursitis. They're injury to the gluteal tendon. So a lot of patients go to their primary doctor and they have pain over the lateral hip, they're tender over there, so they are automatically diagnosed with bursitis. But in actuality, when we look at these patients with ultrasound or MRI, a lot of times we don't see any fluid or inflammation of the bursa. So there's really not a true bursitis. Usually it's a problem with the gluteal tendons, where those gluteal tendons attach to the side of the hip. So a lot of these patients can be diagnosed with gluteal tendonitis. Now, tendonitis may not be the most appropriate term because tendonitis implies that there's inflammation of the tendon. However, if we look at the tendon histologically under a microscope, there's a lot of times not any inflammatory cells. So the tendon isn't actually inflamed. It's more of a degeneration of the tendon. The tendon is degenerated. There are micro tears or partial tears of the tendon that have failed to heal. So it's really a tearing or micro tears of the tendon, not really inflammation. So the term gluteal tendinopathy is kind of the term that we like to use medically rather than tendonitis, as a tendinopathy is probably the more appropriate term from a medical standpoint. What's the treatment? Relative rest. So you want to try to avoid all those painful activities that are inflaming the bursa and the tendon or causing the tearing. Physical therapy to stretch out that tight IT band, strengthen the weak muscles, correct any alignment or muscle imbalance issues. If there is inflammation, non-steroidal anti-inflammatories, added Aleve can help pain and inflammation. And then cortisone shots have been a mainstay of treatment for this condition, as they can help reduce inflammation or pain in the inflamed bursa or tendon. But again, if there is actual tendon tearing, cortisone may not be the most appropriate treatment if it's not really an inflammatory problem. And the downsides of cortisone is that, like we know about cortisone for articular cartilage, for tendons as well, it can actually, if detrimental to the tendon, cortisone can weaken the tendon over time and increase chance of further tearing or even rupture. What about surgery for this condition? Surgery is rarely necessary. If someone goes to a surgeon with gluteal tendinopathy or partial tearing, surgery is rarely recommended. Only if the tendon is completely torn and if there's a large tear of the tendon, then they would theoretically go in and repair it. So it's not a very common surgery. So what about patients who don't respond to therapy and cortisone injections and they're not a candidate for surgery? Well, we have platelet-rich plasma has really been a game changer for this condition. And it's really more appropriate for treating gluteal tendinopathy, where if it's not really inflamed and it's more tearing, micro tears and partial tearing of the tendon, this platelet-rich plasma can actually stimulate healing of the tendon. So you're trying to treat the root of the problem. So again, with platelet-rich plasma, we draw your blood, we concentrate the platelets out of your blood, and then we can inject that directly into the torn or injured tendon using ultrasound to guide us. Now, Fitzpatrick studied this. This was a landmark study, a very good study, randomized, double-blind, clinically controlled trial comparing a PRP injection to a cortisone injection for this gluteal tendinopathy. She published the results in the American Journal of Sports Medicine in 2018, and she continued to follow these patients for another year, so published the 2-year follow-up in 2019. So basically, she compared a single PRP injection to a single cortisone injection in 80 patients with gluteal tendinopathy. And again, it was a double-blind randomized control, so the patients didn't know if they were getting cortisone or PRP, and also the doctors didn't know if they were injecting PRP or cortisone. So very good, high-quality study. And the patients were randomized to receive either one of those treatments. And they found that both groups of patients showed improvement at 2 weeks and 6 weeks. However, at 12 weeks, the PRP group was significantly better than the cortisone group. So 82% of the PRP group versus 56.7% of the cortisone group achieved MCID, which is minimally clinically important difference. And then as they continued to follow these patients, the PRP group continued to improve at the subsequent follow-up visits and had sustained relief at 2 years, whereas the cortisone group had maximal improvement at 6 weeks and did not maintain their improvement beyond 6 months. And that's what we see clinically. We see lots of patients who get these cortisone injections. It helps for a while and it wears off. It doesn't really heal the underlying problem, which is the gluteal tendon injury. And then 27 of these patients in the cortisone injection group who failed crossed over to receive a PRP injections. And these patients also improved compared to baseline at 3 months, 6 months, and 2 years. And Fitzpatrick also at 4 to 5 years out actually did MRI images of these patients and found that the PRP group did show healing of the tendon pathology on follow-up MRI. So yeah, this for all the conditions that we use PRP for in our practice, I think gluteal tendinopathy is probably one of the most successful treatments that we do with the PRP. And
that's great, Dr. Evangelista. Thanks for running through that. A very good overview with a lot of really important information in there. There's some good questions coming in. I'll just remind everybody, if you look at the bottom of the Zoom panel there, you'll see that where it says Q&A, you can type in your questions there, and we'll be happy to answer them for you in the next 25 minutes. I agree with your last comment, Dr. Evangelista, that gluteal tendinopathy is one of the more successful conditions that we treat and is far superior to a lot of the other treatments that are out there, whether it's steroid or, certainly surgery is not offered very often for these patients. But, and that's good news, because someone here asked me, do you have any anecdotal evidence regarding PRP? We actually have quite a bit of anecdotal evidence. We, as Dr. Evangelista indicated, we have a company that we started 4 years ago called Orthobiologics, which is a software platform that allows doctors to track how their patients are doing. So patients get questionnaires every 3 months after their treatment, and that data is accumulating to the point where we have over 10,000 patients now. So these are not patients who are in a clinical study. These are just patients who are being treated by everyday healthcare by physicians across the country. And I don't have this slide, but the data does show significant efficacy in patients both with mild, moderate hip osteoarthritis, as well as with tendon tears, tendinopathy, bursitis. I say this is good news because 11 years ago, my wife injured her gluteal tendon when we fell. We were at a restaurant. They'd waxed the floor. She slipped. 3 ladies fell that night on that floor. My wife suffered with severe hip pain for months until finally we took a look with ultrasound, saw that she had torn the tendon. And this is 11 years ago, so I had only had maybe 2 or 3 years experience with PRP at that point. So I elected to treat her, and happy to report that all these years later, she's still doing very well. Since then, we've treated many patients. I don't know how many. It seems like we see at least one every 3rd day in the clinic who has a tear or tendinopathy in the gluteal tendon. It's extremely common. And as Dr. Evangelista mentioned, most of the time it gets misdiagnosed as bursitis. The doctor will poke on your hip and say, well, it hurts there, so it's bursitis. But if you don't take the time to get an MRI or to use ultrasound and take a look, you'll realize that 99 times out of 100, it's not bursitis, it's actually a tendon injury. And we've had really good results treating those.
Yeah, and I would say as far as factual results for PRP in other areas, I think we see the best evidence for PRP for knee osteoarthritis, tennis elbow, and then the gluteal tendinopathy are the 3 things where there's very solid level 1 evidence for those conditions. I think there is decent evidence for rotator cuff. Anecdotally, I had a PRP in my rotator cuff tear that the surgeon wanted to repair. It was 80% torn. I had a PRP injection, and I'm completely pain-free. And I did actually a follow-up MRI on my shoulder about 2 years out, just curious to see if it actually healed the tendon or if I just felt better. And the MRI actually showed healing of the tendon tear. So pretty, I think PRP is pretty amazing. We start to do it for other joints, and there's evidence for lots of other areas of the body. But again, the most solid evidence is for knee arthritis, tennis elbow, and the gluteal tendinopathy.
Yeah, I think we joke with our friend, Dr. Borgstein, Joanne at Harvard. She's the head of sports medicine over there. And we chuckle all the time about creating what we call the Journal of Anecdotia. It's a journal that would have all these patients that we've treated where it's like, that's the only patient we'll ever see with that very rare tendon injury or that very rare joint injury. And we've had a good outcome using PRP or fat cells or bone marrow cells. And when you only have one patient of a very specific type of condition, you can't do a study because there just aren't enough of them, and everybody's unique. But in more common injuries like gluteal tendon, rotator cuff, tennis elbow. I mean, since we're talking about anecdotal, full disclosure, I've had 2 tears in my tendon, both elbows, and both treated with PRP successfully. So we're really happy for our patients, and we're really happy for ourselves that these treatments are helpful. But there's a lot of published data on Achilles tendon, rotator cuff, and elbow. But today we're focusing on the hip. There's some other questions coming in now, Dr. Evangelista. The first question is there a risk of rapidly progressive hip osteoarthritis if cortisone is injected not into the joint, but instead into the bursa? Does that seem to be associated with problems with the hip joint?
I would say no to that one. It's only been described in patients who receive intra-articular injection of cortisone into the joint, not into the bursa.
I would agree with that. I don't know of any evidence that shows that injecting the soft tissue causes further degeneration of the joint. Although, as you mentioned, there are studies that show that it can cause further degeneration of the tendon, which is not advisable. Tendons, as it is, have a difficult time healing. They have a poor blood supply. Anything we can do to help the tendon to heal, which is why cell therapy is so much more appealing than steroid therapy. If we do a steroid injection, I generally cut the dose down to 1/3 or maybe 1/4 of what we used to do, hoping that minimizes the long-term risk, because there is a short-term benefit to steroid, and occasionally we'll offer it to folks who we think it will help them in the short run. Next question is patients who have pain in the lateral hip, side of their hip, what they call greater trochanteric pain syndrome. If there's calcification, is calcification frequently associated with that condition?
It can be.
Yeah.
Not very common, I would say, but we can see calcifications in the tendon, similar to a calcific tendonitis in the shoulder. We can see that same type of condition with the gluteal tendons attaching to the greater trochanter area, but not very common.
I would say anecdotally, people who've had multiple cortisone injections, I've seen either calcification of the tendon or what we would call fibrosis or scar tissue in the tendon. Whether that's the effect of the steroid or the effect of multiple needle insertions, I don't know. But I would say anecdotally, that's something that we do see. Calcification is not infrequently associated with tendon tears, because when the tendon tears, there is some low-grade local inflammation, which promotes the deposition of what they call hydroxyapatite or calcification in the tendon. Sometimes that's painful, sometimes not. We see a lot of patients who have it, and it's not necessarily a problem for them. Here, one of my patients said, I injected her in the sacroiliac joint because she had pain in her sacroiliac joint 11 years ago when I was a rookie, and said that was a painful experience. And I have a few other patients that would agree with you, but fortunately, the vast majority of the time is not a painful procedure. Probably 85–90% of the time, it's not a painful procedure. There's some tricks we've learned from 11 years ago that minimize the pain. The pain is usually due to one of 3 things. Either if you're not skilled with the ultrasound machine, you can't see where your needle's going. You might touch structures that are sensitive, nerves, for example, that can produce pain. If you inject too much fluid, that creates temporary pressure for a day or 2. You'll feel pressure in that area. That can be painful. And then the third thing is these platelets have the ability to be anti-inflammatory, but they also have the ability to be inflammatory. And the cells decide. And why would the cell want to create an inflammation? Well, inflammation is the first stage of healing. So, I got a cut. So I cut myself working in the yard. The first thing that happens is you get inflammation. Cells migrate to that area to call to attention that the area needs healing. And so other cells are recruited and healing ensues. So short-term inflammation for 7 to 10 days is not unusual and actually desirable when you're trying to stimulate a healing response. And sometimes that's painful. So if we inject the platelets, sometimes patients will be sore for up to a week after the injection. So anyway, that's that. But the good news is we've been doing this for so long now that our methods have improved.
Yeah, and I would say also 11 years ago, some of the systems that we were using back then would include red cells with the PRP.
That's a good point.
Can be very painful, and maybe that's why injecting into the joint with the red cells is a little more painful compared to the PRP we use now. We eliminate all the red cells, so it's a little more pure PRP.
Yeah, that's a really great point. If any of you have had PRP, you look at the solution, it should not be red. It should be completely devoid of red cells, and all that's left are platelets and plasma. And that looks more like pineapple juice and not so much like cranberry juice. So you're right, Dr. Evangelista. PRP that has too many red cells in it is irritating to the tissue and can produce long-term inflammation and pain.
Additionally, I would say that when we inject into a joint, so if you had the SI joint injected, it's usually not as painful as injecting the ligaments. Sometimes we do inject multiple peppering technique to the ligaments of the SI joint, and that's always going to be painful no matter which PRP you use. So I think that also would be
that is one of the key things that I've changed over the last decade. Instead of just putting a tablespoon of fluid in one spot, instead I'll break that tablespoon into a lot of little droplets and just gently put those droplets throughout the ligament or joint. And I think it's better tolerated, and it's probably produced better outcomes too, because you're covering more territory that way. And people generally appreciate not having so much pain afterwards. Okay, next, are there any contraindications to using hyaluronic acid for arthritis of the hip? It's a good question.
I would say no. It's just not FDA approved, but it would be off-label use for the hip and wouldn't be covered by insurance, but it wouldn't be contraindicated.
Yeah, it's a safe product. There was some concern with some of the products that it could raise blood sugar levels, for example, in some patients, diabetic patients. But I would say generally it's well tolerated. All the risks, I would say, are associated with the actual injection. So you want to see a doctor who has treated thousands of patients, is proficient using that needle, using the ultrasound guidance, or in the case of a hip joint, maybe using X-ray guidance to make sure that you're safely and comfortably putting the product into the joint. But it's safe. The issue is it's not extremely effective, and then insurance doesn't pay for it at all. If a patient is on long-term baby aspirin for a cardiac or a coronary stent, would PRP work, or would some activating factor be required prior to injection?
Good question.
Answer it.
That's a difficult question. I would say that it can still work, may not be as effective. I haven't typically activated the PRP prior, but I don't know. What do you think, Chris?
So I have three answers. The first answer is not every patient who had a coronary stent needs, how shall I say, can't go without the aspirin for a week. So the first thing we would do is ask the cardiologist, is it okay if we withhold the aspirin for a week? There are just a handful of papers that show that aspirin does impact the ability of the platelet to release the growth factors. So those molecules that the cell is releasing that actually are responsible for the healing process can be affected by aspirin. The one study I'm thinking of, it was only a 20% reduction in the release of growth factors. So not a huge impact, but an impact nonetheless. The issue of activation, how can I explain this succinctly? Long story short, you probably are aware that platelets are involved in the clotting process. So if you cut yourself, the reason you don't bleed to death is because the platelets form a nice little Band-Aid that seals up the leak. And when we make PRP, we don't want the blood to clot. We want it to spin in the centrifuge, and we want the layers to separate. So we add a anticoagulant chemical that keeps the blood in a liquid state. So that inhibits the clotting ability of the blood. The question is, do we need to add something back before we inject it into the patient to allow those platelets to do their thing, to form clots, to release growth factors? The data is pretty clear that in the case of injecting a tendon, the collagen, the protein collagen, is an activating factor. And so the general consensus around the world, those of us who do this for a living have discussed this, and we agree that in most cases, the simple act of injecting into an area that has collagen in it will create activation and allow those platelets to then regain their ability to do what you want them to do, to form a clot, release growth factors, recruit cells to the area, decrease inflammation. All the mechanisms are functional. So in the early days, activating with either calcium chloride or thrombin was a practice that was commonly used, but I don't really see that as much as we used to a decade ago. Okay, next question. Any clinical trials? We got 10 minutes left to answer another 15 questions. Any clinical trials by either of you? That's a very open-ended question. In the PRP world, currently, we don't have any clinical trials ongoing. However, as we mentioned, we are collecting data on every single patient that we treat. So although that's not a formal trial, we are collecting outcome data so we understand the safety, the comfort, and the efficacy, the effectiveness of these treatments for all the different body parts that we treat. As a side note, we will be doing a study later this year, but it's not on PRP. It's on a stem cell product that's derived from the patient's own adipose tissue. So you'll hear about that in another lecture coming to a theater near you soon. Dr. E, the next one's for you.
Yes. So I noticed that Dr. E outlines PRP in many areas, but not on shoulder issues. What is the best for shoulders, PRP or fat? Good question. There's not a lot of data that I've seen for glenohumeral osteoarthritis. So arthritis of the glenohumeral joint, comparing PRP versus fat. I think we extrapolate a lot of our data from the knee studies and the hip studies and do the same with shoulder. So not a lot of data that I've seen. I don't know if you've seen, Dr. Rogers, any studies for glenohumeral joint arthritis? With
well, let's just broaden the view even further to all arthritis in the body, to all tendons in the body. We don't really have many studies that do head-to-head comparisons of one orthobiologic versus another. We'd like the data. That's why we created the registry, the Data Biologics Registry, that's collecting the data so that patients who are getting PRP, for example, can be compared with those patients who are receiving fat tissue or bone marrow or other treatments. But there's one study where they looked at wrist osteoarthritis. So patients either got PRP or fat cells or both. That showed that fat worked better. I don't think there's any shoulder studies head-to-head. There's one study in the knee arthritis where they compared bone marrow to fat. They were shown to be equivalent in terms of their efficacy. However, the patients who had received the fat tissue were on average 10 years older and had much more severe knee arthritis. So it was not an apples to apples comparison. So there are studies ongoing currently that are looking at this, but we don't have the data yet to make an intelligent comment. So here's our comment based on the best available information. We have many patients who we've treated who have shoulder arthritis with PRP. And most of those patients, 85%, will do well. What does that mean? At 12 months, if you ask them if they're happy with the care, they say yes. So the patients who do not respond, they need something else. And a lot of times we'll escalate to an adipose derived cell treatment or a bone marrow derived cell treatment. And many of those patients who failed the PRP will do well with the fat or bone marrow. So by inference, I say, at least in those populations, there does seem to be an additional benefit for fat or bone marrow. But like I said, no head-to-head comparison studies yet. There's also a theoretical benefit. For example, platelets will last in your joint for about 14 days. That doesn't mean the benefit only lasts 14 days. I mean, steroids only stay in your joint for 24 hours. However, their benefits can last up to 3 months. In the case of PRP, I told you those platelets can stay in the joint for about 14 days, but they can influence the biology so that the other cells in the joint start behaving more normally, and then symptoms can last. I have patients who have, a 6-7 years relief from a single injection. And then when you look at cells from the fat or cells from the bone marrow, those cells have been shown to last in the joint for 3 to 6 months. So theoretically, if you think about the mechanism of how these things work, having that biologic hang around for a longer period of time should produce better outcomes. But we'll see. We'll see what the future studies show. When does a condition cross the line and it becomes necessary to use stem cell therapy as opposed to PRP? You win, Jim. You got the #1 question that we get asked. When would you use a cell-based therapy like fat or bone marrow versus PRP? And the answer is, generally speaking, for milder conditions, PRP is shown to be sufficient. For more advanced osteoarthritis, more advanced tendon tears, a different type of cell-based therapy may be required. We do not call them stem cell therapies. This is a lecture for another day, but it's just my personal soapbox that I always climb on. Stem cell therapy means we're taking a very specific cell, one type of cell, we grow it in the lab. So now you have 10, 20, 100 million of this one type of cell. That is not yet FDA approved in the United States. Nobody in the United States outside of a clinical trial offers stem cell therapy. So if someone says, I'm offering stem cell therapy, you understand that they're not being entirely accurate. But having said that, if we take out a bit of fat and look at it under the microscope, or a bit of bone marrow and look at it under the microscope, there more often than not will be stem cells in those tissues. So the more accurate term in the case of fat, we call it a microfragmented adipose tissue treatment, MFAT, MFAT for short. In the case of bone marrow, we call it bone marrow concentrate, but BMC. There are other cells in the bone marrow. There are other cells in the MFAT. So it's not technically a stem cell therapy, but there might be 1 million stem cells in that MFAT treatment. There might be 50,000 stem cells in that bone marrow treatment. There are no stem cells in PRP. And these stem cells work in ways that are different than PRP. But long story short, PRP for the milder conditions, more advanced therapies for the more advanced problems. You want to tackle the next one?
Sure. I had PRP almost 4 weeks ago in my SI joint, and up until now, I've been disabled. Can't walk or sit lately, not even lay down. The pain afterwards increased terribly. What is the panoramic for this case? We see this occasionally with a PRP injection where you have an inflammatory response that doesn't settle down. Typically, the pain is going to be bad for 1 or 2 days and settles down and then takes a while to work. Now, if you're having that much pain up to, and it's 4 weeks out, you need to come in for an evaluation, in my opinion. Occasionally, I will do a cortisone injection to calm that inflammatory response down if you're having severe pain like that, but it kind of depends on, exactly what's going on in the area that was injected. So in your case, yeah, I would come in to your doctor and have an evaluation to see, what's happening.
Yeah, I agree. I agree with that assessment. At 4 weeks, patients are not cured yet, but they're at least not worse. So if things are worse, there may be something else going on that needs to be evaluated in that case. Would either of you do PRP injection for mild hip osteoarthritis? So I about 7 years ago, treated a ballerina from Los Angeles, professional ballerina, young kid in her early 20s, who had already begun to develop hip osteoarthritis and degeneration of the labrum because of the forces that are put on the joint. And she responded extremely well with a single PRP injection in the joint. Thereafter, I saw a whole entourage of ballerinas with hip osteoarthritis. And generally speaking, they all did very well, partially because they're young, partially because they're healthy athletes, but partially because PRP works really well for mild osteoarthritis. And that's true in the hip, and that's true in the knee, and it's true in the shoulder as well.
What other options besides NSAIDs, PT, cortisone, and PRP are available for recalcitrant trochanteric bursitis? If you've tried all those treatments and have failed, I think other options such as acupuncture would be worthwhile. Shockwave therapy, I think, is worthwhile trying, using sound waves to help improve blood flow and healing to the area. I think surgery would be a last resort. I've seen surgeons do a bursectomy. In my mind, that doesn't make sense. And you also want to make sure that is the pain really a bursitis or a tendon tear, or exactly what the pathology is. I've seen patients with an L4 radiculopathy, L4 nerve root, and that's causing the lateral hip pain, and that's the problem. So one, make sure you know the diagnosis, and then two, if you failed all those treatments, I think acupuncture and shockwave would be reasonable.
I agree. And unfortunately, we're out of time. I really feel bad when people have questions still. So in 30 seconds, I'm going to answer the last 5 questions, if that's all right. We don't know the minimum dose of number of platelets, but we think it's probably about 5 million for a hip joint. It's probably, billion, and it's probably 10 billion for a knee joint. As I told you, we count the cells, the platelet cells in every PRP that we do, and we compare that to the patient's outcome. And early data is suggesting that those numbers are holding true. If you don't get enough cells, you just draw more blood, and then you got more cells. Insurance does not cover these treatments, that's the major downside to these treatments. These cell therapies are not yet covered by insurance, and we can customize the care, so the price varies widely depending on how much or how little treatment you actually need. Everybody else said thank you. Okay, you're welcome. Thank you for your time and your interest, and we look forward to meeting you in person if you need us, or your friends or family if they need us. And thank you to Dr. Evangelista. You really did a great job running through
Thanks everyone for joining.
Thank you. Have a great day.
Bye-bye.